Are you feeling lost about your SCA preparation? Maybe you don't feel your preparation is going well, or you don't feel confident about this exam. In this video, I'm going to show you how to prepare for this exam, what high performers do to score well, what are the pitfalls and challenges that GP trainees face with this new exam. If you want to apply proven strategies and pass your exam, make sure you watch this video until the end. For those of you who might not know me, my name is Dr. Erwin Kwun. I'm a portfolio GP. I'm on a mission to help doctors lead a fulfilling life. The reason I set myself on this mission is during my training, I've been experiencing quite a lot of up and down, and there were times in my training where I saw GP trainees and other doctors who were struggling a lot. And at some point I thought that there must be something that we need to do for doctors, because I believe every doctor needs to get the support they need so that they can have a fulfilling life. I'm also a big proponent of coaching. I've benefited a lot of coaching myself, and this has been a catalyst in my career. So I hold a PG cert in applied positive psychology and coaching psychology, and I've used that in medical education and found it really effective to get results. Just tell you a little bit about my training. So I passed my MRCGP SCA in December 2020 first attempt, and since then I've been helping GP trainees with their communication and consultation skills, helping them to get through the exam and CCT. In the last couple of years, we've supported over 178 GP trainees to achieve their goals. Some of you might know the YouTube channel and you might have watched some of the videos. Recently, I interviewed Dr. Erwin. If you haven't watched this video, I really recommend that you go and watch it, because Erwin is a renowned expert in general practice consultation, and he shares his insights in it. Question for you guys: how are you preparing for your SCA? Let me know in the chat box what is a method that you're using right now. Some of you might be using method B, or some of you might be doing C right now. And let me know what you're doing. Most of you are practicing cases from books. Emmanuel is also reading books and guidelines. So what are you going to learn today? I'm going to show you what to expect with the MRCGP exam. We go over the content, the format, and also the challenges that GP trainees face for this new exam, and what are the pitfalls. And more importantly, we're going to look at how you can prepare for your exam and how you can pass. The simulated consultation assessment is a new MRCGP assessment that is set during your ST3 year or later. It's going to be conducted in a local GP surgery, most likely in your own GP practice, or it could be a neighboring GP practice. The exam fee has been set at £1,180. You'll get 12 simulated consultations, 12 minutes to consult, and you'll have 3 minutes before each case so that you can prepare for the consultation. So the format of the exam involves simulated actors. So these are actors who have been trained and they've been given a script. The role players have been calibrated to make sure that it is standardized. So you can expect a variation of approximately 9 videos to 3 telephone consultations, although this might vary. The cases, all of them are going to be recorded remotely and then viewed and marked at a later date by examiners. One thing to note is that physical examination is not going to be assessed in this new SCA exam. However, there might be cases when you feel a patient might need to be examined physically. So you can offer to examine a patient physically by making an appointment with the patient. However, you won't be assessed for that, because the SCA is not really the best format to assess this type of physical examination. But there might be cases where you're given the observations. For example, you might see on the case briefing and case note what's been done. There are other times when the patient may already have checked their temperature or their blood pressure. So if you ask for it, you might get the vital sign from the patient. So that helps you to make your management. Having said that, it's important to make sure that you're still managing the case, because if you're just making a plan to see the patient face to face, that's not going to be enough for you to score well. So you need to have an endpoint where you're solving the problem that you're presented. So what can you bring? You can bring a paper copy of a BNF and children BNF. You can bring a whiteboard and a pen. So if you're planning to get a whiteboard and a pen, I'd suggest that you do it early so that you can get into the practice of using it in your rehearsal. And you're also allowed to bring a bottle for water or a glass of water if you need. The exam dates have already been confirmed. If you're sitting in November, you already have your exam dates. And if you're planning to sit later, then you can reserve which sitting that you're going to take up until 12 months, and then you will get an email with a booking link so that you can book. So it's important that you decide which sitting that you're going to go for. So with this exam, it's important to know how it's going to work. So if you're given a morning slot, then you will come at 9 o'clock. At 9 a.m., you'll have to log in on the IT system. So it's Osler IT system that's being used to conduct this exam. And you'll have an ID check and also environment check. So the thing is, you need to make sure that you have a webcam that can show the other person that's going to do the check whether there's any things that might not be allowed. So that's what they're going to do. And then at 9:30, the examination starts. You'll start with the first part of the cases. So the first half, cases 1 to 6. And then after that, you'll have 10 minutes comfort break. And then the exam resumes at 11:10. So then you'll do the 6 remaining cases. Now, there are times when there might be need for reruns. For example, if there's a connection problem or there's IT glitches, then some of the candidates might need to rerun some of the cases. There's also reasonable adjustment that's allowed. So for example, if you do have any illness or any disability, I suggest that you request whether you're eligible for any reasonable adjustment, because then you may have extra time if needed. The exam ends for everybody at 1:20. And if you've got an afternoon slot, it's going to be a similar process, but you start at 13:40 and the exam ends at 6 p.m. When you look at the cases that you're going to do, so you're going to have to do 6 cases consecutively, and then you'll have a comfort break. It's very important that you make sure that you focus on the case that you've got at present. Sometimes during an exam where you're stressed and under pressure, you might be worried that maybe you haven't done X, Y, or Z, or you should have done X, Y, or Z. But if you're on case 2, don't worry about case 1 because it's already done. So you don't want to focus on case 2 where you can score the maximum mark that you can. Don't allow a previous case to affect the future cases that you're going to consult. Because if that's the case, then you're going to find that you're just going to be in the wrong state of mind, and that's not going to help you to score well. But if you take each new case fresh and focus on that, then you might compensate for any mistakes that you've done previously. The 3 minutes reading time that you're allocated is very important how you use it. Because if you don't use it strategically, then it's going to affect the performance in the consultation. So Benjamin Franklin had a quote where it says, "By failing to prepare, you're preparing to fail." So this comes down to how you're preparing the case before the consultation starts. So when you prepare the case, make sure that you have a process. You know what you're doing in the prep time. So preparation is key. Read the case briefing carefully, study the patient's case note, make sure that you take note of any relevant key points, think about any red flags or any differentials, jot them down on your whiteboard if you're using a whiteboard, or if you're not, then you can use the IT system and make note on that. Then what I suggest you do is play the consultation in your mind. Anticipate what issues you might encounter and consider what possible solutions and management plan you might need to discuss. The consultation starts before it even happens. By playing it in your mind, you're going to find that when you start the consultation, you're in a better position and the consultation is going to run more smoothly. So let's prime this case together. Let me know what you're thinking when you're reading this, the case briefing. So we can see that this patient was seen by the district nurse, and this district nurse was seeing the patient's wife and then found out that Mr. Robert Jones was not looking well. So the district nurse alerted the GP and also did some observation, which is quite useful for us. Tell me what you're thinking when you're reading this case briefing. So in the case briefing, we don't know the age of the patient, but let's have a look at the case note. So the patient is 67 years old. As you can see, the patient has got some past medical history. So if the patient has got a long list of past medical history, make sure that you read carefully and think about which one are relevant in this history. In this one, essential hypertension, CKD stage 2, the patient is on some medication. Some of them might be an issue if the patient carries on taking them. So for example, ramipril, amlodipine. And we can see that the normal blood pressure has been stable at 142 in the past. But recently on that day, the blood pressure of this patient appears to be quite low. So when you're priming this case, then you're thinking about what are the possible problems in this case. For example, is this patient vomiting? Is this patient able to keep down fluid? Are there any possible causes of diarrhea? It could be gastroenteritis or diverticulitis. Maybe the patient is at risk of dehydration. There's a risk of AKI on CKD. You might consider whether you want to stop ramipril and amlodipine. Think about the red flags that you might want to ask, and explore the idea, concern, expectation as well. So in this situation, if the patient is also carer for the wife, they might be reluctant to be admitted in hospital. Then in your management, how are you going to readdress that? And what alternative management are you going to offer? So think about the psychosocial, the situation. Priming is really important, and the 3 minutes reading time is key. Once you've done that, then you have 12 minutes to consult. In the consultation, when you have already played out the consultation in your mind, then your thoughts are going to be more organized and you will know exactly what is your game plan in the consultation. And then you might be able to make a better plan if you've done the groundwork of thinking it through beforehand. So what is the purpose of the SCA? The purpose of this exam is to see whether candidates are able to keep patients safe, that you're able to work at a level that is safe, and you're showing that you're as an independent GP. That's the level that we're looking at. And it needs to be showing that you're able to adapt the way that you're treating different types of patients and illnesses, and also about managing risk, how you're managing risk, medical complexity, and managing uncertainty. The examiners are also looking at how you're exhibiting appropriate behaviors, attitudes, and concerns for the patients that you've got, or the simulators. So it is a behavioral assessment. So if you're not saying something, the examiners won't be able to read your mind. So it needs to be verbalized. So there are 12 clinical experience groups that have been decided, as in what are the cases that you might get. So you will get a case in each of these 12 clinical experience groups. It's key that you identify which are the areas of weakness you might have. Typically, for male GP trainees, they might struggle with gender, reproductive, and sexual health because they might not have a lot of exposure in that. Other cases that might be a struggle for GP trainees are the cases involving professional conversation and professional dilemma. So these are cases where it can be difficult. For example, if you're discussing with another healthcare practitioner about something that's quite difficult. For example, let's say that you've got another doctor who is consulting you about their health problem, and they might have some problem with alcohol dependence, and that's going to be very challenging. Or you might have a new patient who is diagnosed of HIV, and they don't want their partner to know about it. So there is a professional dilemma here. So think about what case scenarios that might come up, and if you're thinking about these scenarios and practice them, then it's going to be good preparation for you, because you don't want to be doing it in the exam first time. You want to have already practice these types of scenarios. So how is exam marked? So there are three domains that you're going to be assessed upon. The first one is data gathering and diagnosis. It used to be just data gathering, but now with this new dimension with the diagnosis, you're also expected to make a diagnosis. So not just taking the information and taking a history, but also thinking about how you're going to come into working diagnosis. The second domain is clinical management and medical complexity. So this is a domain that a lot of GP trainees get stung. It's important that you structure your clinical management. So complexity is another layer of complexity where you're having to manage comorbidities, or you might have been managing other situational problem as well. So it's not just a medical exam where you're managing just a medical aspect, but you might be managing psychosocial complication as well. The last domain is relating to others, which used to be interpersonal skills. So it's about how you're building rapport with your patient and developing the relationship, and also being able to recognize any safeguarding concern in the consultation, and how you're managing patient in a person-centered way. So you're going to be awarded grades for each of the domains, and there are 4 grades: clear pass, pass, fail, and clear fail. Clear pass is when you demonstrate that you're consulting at a level that's above the standard of a newly qualified GP. Pass is when you demonstrate that you're proficient and you're at the level of a newly qualified independent GP. Fail is when there's insufficient evidence to suggest that you've got that level. And clear fail is when it's clearly below the standard. To score a pass in data gathering, the key here is to be systematic and make sure that you structure your data gathering so that when you're taking your history, it's targeted. You're not just blindly asking history where you're general, but you're utilizing the information provided and making sure that your history is focused. And when you're taking the history, you're also considering what are the potential differentials and thinking about how you're going to manage it as well. So before you can manage it, it's important that you try and see whether you can come into working diagnosis. So in clinical management, what you want to do is demonstrate that you're able to formulate a safe and appropriate management plan. And this might include how you prioritize various problems in the consultation, and also showing that you're a person who's looking not just at the medical management, but also looking at various things such as lifestyle modification. So not just short-term fix, but long-term, how you can support the patient to self-manage the ongoing problem. So it's a mix of short-term and long-term. So how you get optimize the care of the patient in the limitation that you have as a GP. And relating to others is where you demonstrate various aspects such as ethical awareness, your ability to communicate in a person-centered way. And doing that remotely can be challenging because when you're speaking to a webcam, then you won't have that energy that you have in person when you're speaking with somebody in a consulting room. So you need to make sure that you're able to convey the same level of emotions and energy via a webcam. Are you struggling with your consultation skills? Maybe you need help and you want to get constructive feedback. If you'd like to get help, then click the link down the description below to see whether I can help you. If I can help you, then we can enroll you on the one-to-one coaching program. How do you demonstrate your initiative and your ability to manage various problems? And this could be communication barriers. This could be how you make sure, for example, if you've got a patient who is not able to talk, so you're having to talk to a third party. So it could be a carer, how you're going to take a focus history and manage it. You'll also have marking on the global. So each of the cases will be marked globally. So it's pass, bare fail, or fail. You might feel like, what would be the pass mark then? It depends on how the whole cohort does in general, and then the pass mark is going to be established. You won't need to pass a specific number of stations in order to pass. So it's about the overall mark that you're going to score. The clinical management domain and medical complexity is going to be more heavily weighed compared to the other two domains, which make it even more important for you to focus on the second half of the consultation, how you're managing the problem that you're given. So far, we've covered the introduction to the MRCGP SCA exam. Next, we're going to look at the challenges and pitfall of the SCA. Commonly, GP trainees fail their exam because they sit the exam too early. And this has been the case for the CSA and for the RCA. If you have not got enough experience of general practice and you're rushing to sit it, you might not be ready for an exam where you're going to be tested to the level of an independent GP. So the timing is very important. You need to work through how many a month you might need to be able to get to the level that you're comfortable to sit the exam. Inadequate preparation is another one where GP trainees may underestimate the exam and don't take it seriously. Poor time management is a big one. A lot of GP trainees struggle with their timing. So in the video case example on the college website, where you can see some of the SCA cases, most of them, the doctors in this consultation are struggling with their time. Some of the consultation are running beyond 15 minutes. So getting a grip on the timing is really important. The various causes why somebody might be taking too long, and it's important that you diagnose the problem and work on each of these problems that's causing your consultation to go far beyond the time of 12 minutes. Another problem is doctor-centered care. So if the consultation is doctor-centered, then you're not going to score well. And this is where the relating to others is going to be very low. A common problem that GP trainees encounter is lack of confidence. And this comes from people who might not have English as their first language. So they might struggle with the accent, or they feel like they can't communicate with confidence. So this is something that it's going to take you practice, repetition, refining your consultation, and build your confidence to get to that level that you're confident, especially for an exam where stress is quite a major factor, because on the exam day, you might be nervous. So you need to tackle this problem and have strategies how to tackle this anxiety. Another problem is overconfidence. Some GP trainees might not know where they are at, and they might be overly confident, even though they are not very competent. So you don't want to be there neither. And this is where they might not be getting constructive feedback. So if they are being given general feedback that they're doing well, then they might feel like they're good and they're ready to sit the exam, when actually the case is they might be consulting below the level that's required. Another problem is struggling to take a targeted history. So some GP trainees might struggle because they don't have a good structure. Insensitivity and not being able to empathize naturally is another issue. Sometimes GP trainees have got stuck phrases that they use, but they don't sound empathic, and you can't really fake it. If you don't mean what you're saying, and if you're not congruent, then the examiner can tell, the simulator can also pick that up. Another problem is listening. Listening is a very overlooked skill in communication skill. Most people feel like their communication skill is good, they're listening well, but actually listening is something very difficult, because sometimes people listen not to actively listen, understand, but so that they can speak next. They're listening at the same time they're thinking about what to say next, what question to ask. And then they forget things, they don't pick up things, and then they don't respond to cues. So these are common points of challenges and pitfalls to avoid. Really important that you learn from mistakes. And learning from your mistakes is good, but learning from other people's mistakes is going to save you time. So learning from others' experience. This is where it's important for you to read the feedback statement. The feedback statement shows you exactly what are the common pitfalls and where you need to focus your attention. So when we look at data gathering and diagnosis, commonly observe that GP trainees, they don't take a sufficient history to enable a safe assessment. For example, if you're taking a mental health history, it's really important for you not to miss risk assessment. You want to make sure that you check whether there's any risk factors, whether there's anything that could lead to a safety issue. For example, if a patient is got alcohol dependence and they're driving, there's safety issue there. Another problem is where the structure is not there. So the history is being taken in a very disorganized way, and the candidate is jumping back from clinical management to data gathering, and it's just not structured. And this is where there is a risk for you to miss something very important. Last one I'm going to point out here is where candidates are not thinking about their differentials. So if a patient is presenting with low mood, sometimes you might feel like this is depression, and you're just asking about all these questions about depression, their sleep, their fatigue, or their level of energy, or their mood, but you're not asking other questions to find out whether it could be bipolar disorder, whether it could be anxiety, or whether it could be if the patient has got schizophrenia. So you want to ask a few other questions to show that you're doing a workup to exclude other differentials, so that you're not jumping to a conclusion too soon, thinking that this is depression. So in clinical management and medical complexity, there's 9 statements. So make sure that you read them and read the explanation details on the college website. So management plan relating to referral was inappropriate or not reflective of current practice. Let's say you've got a patient who is presenting with gout, and the patient would like to have a referral to rheumatologist. If you do that when it's not expected for a patient to be managed by a rheumatologist if they've got gout, then it's not appropriate. So it's important that you might have a difficult discussion with the patient to explain that this is not something that would be done. You can manage it very well in general practice setting. So you need to know what other referral you're doing, and also whether you're doing a routine referral or an urgent. If something needs to have a routine referral and you're doing it as an urgent, then that's not appropriate neither. So you need to know not just which specialty to refer, but also the urgency as well. The second one here is about prescription. So the management plan also needs to be related to prescription decision that you're making. For example, the case that we've just discussed, where the patient was on amlodipine, on Ramipur, so their blood pressure is low and they're at risk of dehydration, you want to discontinue that medications so that the patient is not at risk. So it's important to think about what prescribing decision that you might need to make. And you can already think about it in the priming stage. What are your clinical management decisions that you might need to make? Another one here is not discussing the risk of your medical plan. So it's important that you help the patient to make an informed decision. If you're discussing a medication, for example, if you're discussing a medication that has severe side effects, for example, if you're prescribing a patient with Bixaban, you want to tell them about the risk of bleeding, because there might be implication if they have a fall later. So it's important that you discuss the risk appropriately without scaring the patient. And last one that I'm going to point is time management. This is really critical. If your time management is not on point, you're not giving yourself at least 5 minutes. Sometimes 6 minutes can be difficult, but at least 5 minutes to manage it, then you're going to rush and you're not going to do a good job in the clinical management. So this one is important that you look at, not just in the clinical management, but it needs to be in the data gathering. Because if your data gathering is not targeted, you'll find that you're taking too long in data gathering, and that has a knock-on effect on your clinical management. The last domain is relating to others. So this one, I understand that some of the IMGs struggle a lot with this, where you find that your consultation is not flowing well, you don't know how to show empathy. It can be very difficult. But what examiners are looking for here is somebody who can show their human aspect, right? So it's not about like just going through a list of questions and being formulaic, but you want to show that you're understanding the patient as well and how you're going to respond as a human being. You don't want to sound robotic. So communication skills, including nonverbal, responding to cues, active listening, were insufficiently demonstrated. It's important that you analyze your communication skills. So how you come across, whether you're good at active listening, and whether you're good at picking up these cues. Because in the exam, the simulator, if you haven't picked up a cue, they're likely to drop another cue for you to pick up because their role is to help you with it. But if you miss it again, then they might not actually drop another cue for you. Then you might miss the whole heart of the case. So it's important that you actively listen. The next thing I'd like to point your attention to is ownership or responsibility for decision making was inadequate or inappropriate. Sometimes I've observed GP trainees feeling like they need to give options to the patient. And some of the options they give are not good options. So if you are discussing with the patient who needs to have an admission, you're just saying, we could treat you with some medication at home, or we could admit you. Which one would you like? So this is not really a good way of discussing it, because as a doctor, it is your job to provide the best care for the patient. So if you're giving option to the patient when you know the best recommendation here would be for an admission, then you're not taking responsibility of the decision making. So the way you do that is to explain to this patient, I understand that you don't want to go to hospital because you don't want to leave your wife on her own. However, I am concerned about your health here because you're not able to drink, and I'm worried that you might be dehydrated. So that's why I think it would be important if we can get you seen in a hospital. What do you think? So you see, I am allowing the patient to make an informed decision. I'm giving this patient opportunity to contribute to the management, and I'm also making sure that I'm giving him the best care. But if I just said, we can do this or we can do that, which one would you like? That's not taking responsibility. So we've covered introduction to the MRCGP SCA, challenges and pitfalls of the SCA. Now we're going to look at how to prepare and how you can pass your exam. So a quote that I'd like to share with you is, we don't rise to the level of our expectation, we fall to the level of our training. So this is a very important concept. If you're going to sit an exam, it's not a good idea to just hope that on the day of the exam, you will somehow be able to consult within 12 minutes if you haven't been practicing at 12 minutes, if you haven't been doing these difficult, challenging cases. So when you've done the difficult cases, the challenging cases, you make sure that you are consulting within the time constraint, then whatever cases you might get on the day of the exam, because you've trained hard and you've been able to go through various challenging cases, then you will fall to that level of training. So I hope that makes sense to you. So let's take a look at what high performers do to score well in the exam. They plan early. They make sure that they take the exam seriously, and they give themselves time to plan and prepare early on so that they are not rushing their preparation. They develop self-awareness. They're aware that they're not everything that they know, so they're aware that they might need help. They also foster a growth mindset. This is where they're always learning from other people's experience, learning from other mistakes so that they don't make the same mistake. And that can save them a lot of time and energy. They also understand what examiners are assessing. So they study the exam. They don't just read what's on the website, but they digest it and they understand from an examiner's perspective. The high performers tailor the revision to address areas of weakness. Some people might know their areas of weakness, but they shy away from these areas of weakness. Whereas if you want to score well, you need to tackle these areas. And this is really important. High performers, they're not afraid of feedback. Sometimes it can feel uncomfortable to get feedback, to be told that you're not doing something well. However, high performers understand the value of feedback. They know that feedback is valuable for them to unlock new things in the consultation that they might not be aware of, identifying the blind spot or shortcomings so that they can develop. So not only do they accept feedback with open arms, but they reflect on the feedback and they're learning how they process that feedback. And high performers, they're able to consult effectively within 12 minutes. They've done it so many times that they have got the strategies to consult within 12 minutes. They made sure that they embed good consultation practice and develop their own style. So it takes some work to do that. Once you've embedded good consultation practice, it comes as second nature then. Under stress, you will still be able to consult well because you have got that good habit. Whereas if you've got these poor habits of not consulting well, then it's going to be more difficult. You have to unlearn that first and then learn the good habits and embed the good practice. So how are you going to prepare then? So really key here is your state of mind. A lot of GP trainees think that the gap of knowledge or skill is an issue. However, the gap of knowledge and skill is not the only things to look at. You also need to look at your attitude to this exam. How you're approaching this exam is also important. So for example, when I'm saying attitude, it is about having an open mind, being somebody who's curious to learn and showing that you care for the patient as well. If you don't have that type of attitude, then even if you've got the best skill, even if you've got all the knowledge, you're not going to be consulting in alignment and you're not going to be congruent. Whereas if you're consulting and you have got the positive attitude, your skills are on point, then you will naturally develop the behaviors that will help you to score well. The state of mind is important, how you approach this exam and your mindset. Then it comes to the strategy. So working smart is really important. You don't want to just work hard and just practicing cases here and there. You want to work strategically. And this is where a lot of GP trainees don't have a system to follow. So when I say working smart, what I mean is that take your exam seriously, decide which sitting that you're going to take the exam, reserve it, and start planning at least 6 months before the exam. Make sure that you're using your exam leaves, you're using your study budget, because you've got that to use towards your exam if you want to. If you don't use it, then you're going to lose it. So make sure that you're proactive at organizing things. Identify your blind spots and areas of weakness. For example, if you're not very good at sexual health or gynae, then you could consider arranging a half-day release at the gynae outpatient clinic. You will get some experience. Give yourself ample time to embed consultation skills. Seek regular feedback and make sure that you keep adjusting your consultation. Another thing that's really important that some GP trainees know they should be doing, but they are not doing, is record your consultation. So you have got cuts that you need to do, you have got audio cut. Why don't you use it at the same time as you're preparing for your exam? So you're killing two birds with one stone. You have to do it anyway. So do it and use it for your SCA and target the cases in the clinical experience groups and look at what are the areas of weakness you might have and do some recording, and that will help you to analyze with your supervisor. Join a study group if you can with other trainees. Ideally, you want to join a study group with other trainees who are sitting the exam at the same time as you. If you're joining a study group with somebody who's sitting the exam in February when you're sitting it in November, for example, they might not be at the same pace as you and might not take it as seriously as you. That's why you want to have somebody who's taking it at the same time. Sometimes GP trainees struggle to get good study group going. I understand it can be difficult when everybody is busy, but it's effective. Organize joint consultation with your trainer. This is an opportunity for you to learn to manage risk and uncertainty from someone who is more senior. They might have some pattern recognition. They might have some tools that they share with you. And then develop your skill at managing complexity. This is where you expose yourself to complex cases. So the structure is really important. Make sure that you develop your own structure. I share with you a structure that I use. So in the 3-minute reading time, it's really important that you prime your case. In the first minute of the consultation, encourage the simulator to tell you the story. They've got a script, and if you ask open question, you will get most of the story out there. If you don't do that, or if you interrupt them in the first minute, then you'll have to work harder to get the story because you've cut them off. So make sure that you listen actively to what they're saying. Then at around 1 minute to 2 minutes, elicit the patient's idea, concern, expectation, because you want to know what's in the mind so that you know how this consultation might develop. Then think about the medical history, how you can come into working diagnosis, explore what's the issue. Don't forget your red flags. Then think about how is this illness impacting on your patient's life. So the patient is also a person and has got other work life or home life. So make sure that you elicit that as well. Common mistake I see is GP trainees just asking, who lives at home with you? Or do you smoke? These questions are very formulaic. You don't want to ask formulaic question. It's better to ask it in context. For example, how is this headache affecting you? Have you had anything that you had to change because of this headache? So you're asking this question that's putting it in context with the headache. Once you've got the eyes, you've got the medical history where you can come into working diagnosis, and you've also got the situation as in the context, the psychosocial, then it's time for you to move to clinical management. It's very important that you get mutual understanding with your patient. If your patient is worried about brain cancer, but you think that the patient has got migraine, it's important that you get on the same page. Because do you think a patient who is worried about brain cancer is going to be open to listen management of migraine? They need to know that you have listened to them and you readdress their concern. So you might tell them, I appreciate that you were concerned about a brain cancer. Having listened to you today, I don't think this is a case because when I asked you various questions, you do not have any symptoms that's concerning. However, what I think you've got is migraine because you're having this headache on the right side and also been having some nausea and sickness. What do you know about migraine? So you see how readdressing the patient's concern and explaining what I think is going on. So the patient feels understood. They feel that you have not dismissed their concern. Then when you discuss the management of migraine, they'll be more open to listen to what you have to say. So then in the clinical management, I might say to the patient, I understand that you are hoping for a scan. We don't normally arrange scan for migraine. It is a diagnosis that we can make clinically. Actually, arranging a scan for you might actually be against your interest because you might get unnecessary radiation that could increase your risk of cancer. But I can tell you what we can do to help with the headache that you've got. I understand you've tried paracetamol, it's not working. There's a more effective treatment called sumatriptan. Would you like me to go over this with you? So you see how I'm progressing the consultation? So I've readdressed the expectation as well. And I'm explaining what we can do to treat this headache. So then you have to discuss not just the medication, but you have to also explain how to take it and the side effects. And also you might consider any triggers. You might want to tell the patient whether they could keep a diary of the headache. and arrange a follow-up in 3 weeks' time to see how they responded. Lastly, you want to make sure that you're safety netting the patient. Because you're worried about a brain cancer, you might tell the patient what are the warning symptoms to look out for. So once you've done that, then you're showing that you're consulting at a level that's above or even higher than the standard. Let's say you get this for your exam. How are you going to prime this case? Tell me in the chat box, what are you going to do in your priming? What's coming through your mind? What are you going to make note of? Let me know in the chat box. So this case is about HRT requests. You've got a patient who's coming because they would like to start HRT. There's quite a lot to cover in this case. If you don't plan it, then you might find that you struggle to finish this on time, especially if you haven't practiced and you don't know how to explain things. So in the priming, think about what are the symptoms that the patient is experiencing. Explore the gynae history. Explore whether the patient is on any contraception, when was their last menstrual period. Explore whether it's suitable for them to start HRT, whether they might be having any contraindication. Explore the patient's health agenda, as in, do they have any concern about starting it? What's the expectation about HRT? And then consider the psychosocial as well. So this is a game plan, how you can approach it. So thinking about the problem and thinking about whether it could be something else going on as well. And in terms of the psychosocial, making sure that you're thinking about how is this affecting the patient's life. Think about the lifestyle modification that you might need to discuss. Smoking is one of the things that some of you mentioned. And then it comes to the management, where you're thinking, which HRT am I going to start for this patient? Okay. So question for you, which one of these 4 HRT would you prescribe? Right. So some of you are asking whether it's about patients still having period or not. A lot of you thinking about Everard Conti patch. So really important, first of all, we establish whether the patient has got a uterus or not. If the patient has got a uterus, then the management plan will involve estrogen and progesterone. If they don't have a uterus, then it's an estrogen only. The next question is whether the patient is perimenopausal or postmenopausal, whether the patient's been having period in the last 12 months or not. Now, if a patient is perimenopausal, then the management will be cyclical combined therapy, and this will be either oral or transdermal, depending on the preference and the risk factors. If the patient is postmenopausal, then we're considering continuous combined one. So oral one will have a kilofem. If you're thinking about transdermal, then it's Everard Conti patch. So making that decision might take you some time if you're doing it first time. But if you've gone through it a few times, then when you're going to sit your exam, then it's going to come more naturally to you. Question to you, does practice make perfect? Because that's something I've heard a lot. What do you think? I got some yes, no, usually, definitely. Okay. Let me share with you a story. Meet Dr. Inamuna Berega. He was stuck in training for years. He failed his MRCGP exam 4 times. And this had significant consequences to his training. His CCT was delayed. Out of interest, Tell me, what do you think is a pass rate among IMGs for the clinical component of the MRCGP exam? Some of you are saying A, B, some of you are saying D. The stats are quite stark contrast between UK graduates and IMGs. As you can see, among IMGs, the pass rate has been under 50%. So in the days of the CSA, it was even lower. And I suspect with the new SCA exam, it's probably going to be around the same level, because probably with the RCA, the reason it's been going slightly higher was because GP trainees had the luxury of picking and choosing which cases they submit. Whereas in the new exam, you won't have that luxury. You won't have the ability to choose which cases you do. You'll be given a set cases. So as you can see, the odds were not in favor of Dr. Inamuna. He struggled a lot and he failed it 4 times already. The consequences of not passing his exam, of having to extend training, was not just financially, where he had to pay for the exam 5 times. He was also at rock bottom. His confidence level was down. He was feeling depressed and his career was on the line. But he was given an exceptional 5th attempt to resit the exam. And a lot of people think about the consequences of not passing, the exam fees, and the personal impact. But a hidden cost that nobody talk about is he was doing the exact same job as a GP who was possibly a salary GP at his level, but he could be earning more. But because he was stuck in training, he was losing 50 grand annually, just because he was not a qualified GP. And he was doing the exact same job. But that's the hidden cost of having to extend training and not having passed his exam. And this is really a significant cost because he was stuck in training. So after failing 1 exam, 2 exam, 3 exam, 4 exam, it was just a downward spiral. But luckily, he decided to change his preparation because he realized there was something not working. Practice does not make perfect. What makes perfect is when you keep practicing and refining it. And I don't think you should be aiming for perfection, to be honest. I think you need to be aiming for progression. And a major weakness in the preparation of Dr. Inamuna was he was not getting honest, constructive feedback. So just practicing and doing the same thing and getting results that he was dissatisfied with. But when he changed his approach, he started seeing difference. So he consulted, assessed himself, sought feedback, made adjustment to his consultation and implemented the changes, and his consultation got better. And he managed to pass his exam on his 5th attempt. Not only did he pass it, but he scored 164. He did not fail any of the cases, which is quite remarkable for somebody whose odds was against him. So if you'd like, I'll show you what we did for Dr. Inamuna. If you'd like, I'll share this with you. So this is where having a strategy, having a complete blueprint is really important. When you have a blueprint, you're not just doing things here and there, cases here and there, but you're following a proven strategy so that you're working on your consultation and make sure that you're preparing yourself to score higher. And this is where consultation blueprint comes in, where you look at your foundation, how you consolidate any areas of weakness, how you polish your skills, you fine-tune things, so that when it comes to the exam, you're ready and you're able to score well so that you don't have to fail the exam. And a key part of that is a SCA companion. This is something that a lot of GP trainees in the program have been using, and it's helping them to save time and also to make sure that the practice that they're doing is not just practicing cases, but they can monitor the practice and they can be strategic, as in following a guide where they're going. So they can track their progress and reflect on their learning. Everybody who is here today live will get access to this SCA companion so that you can start using that, because you will find that when you use that, it's going to take your preparation to a new level. In the blueprint, you will have a community of other GP trainees who are working towards the same goal of passing the exam. And I will teach you everything you need to not only prepare for your exam, but also to make sure that you do it in a way that's going to save you time and energy so that you don't have to try things that don't work. And you will also have access to 20 high-performing SCA consults that cover the 12 clinical experience groups. So these are simulators that have been trained. One quote that I'd like to share with you is, I hear and I forget. I see and I remember. I do and I understand. This quote by Confucius is really important because when you're learning a skill, it's not enough just to hear and to see, to watch videos. You actually have to do it. For example, if you're learning to swim, you have to get in the water and swim. This is where the immersive workshop comes in, where we have 10 simulated role plays, and you get a chance to practice role plays and receive feedback. We just did one on Saturday, and this was a feedback from one of the attendees. Very difficult case, practicing it with friends just does not make the case justice. And this is Rachel, one of our simulators. So you will be able to experience what it's like to consult a simulator. And we go through very challenging cases, difficult cases, such as safeguarding issues, such as ethical dilemma, which is something that you really want to do before your exam. This is Sana Khan, who passed her RCA. She struggled a lot with her exam because she had crippling anxiety. And she couldn't find a solution. She worked with her CS and ES and couldn't find an answer. But then she got in touch with me and we worked towards a strategic plan, as in how she could prepare better. And she managed to pass her exam, and she's working also doing a portfolio type of career where she's working in emergency as well. Maybe you remember Dr. Inamuna. So he's working as a GP, and this is what he said. So we've got over 55 testimonials, and this program is going to be refined and refined. And as we keep refining it, you're going to learn from the experience and the mistakes of hundreds of GP trainees. So if you want to get one-to-one support, you will get everything I've just discussed. Plus, you will get a strategic plan tailored to your specific needs, personalized action plan. You'll also get constructive feedback and personalized support. You'll get this in the form of a one-to-one intensive coaching with myself. And all of this is normally worth £1,199. But if you book, then you will get it for only £899. And this is a limited offer because I can only coach a select few number of GP trainees. If you're going to prepare and you think that what I've discussed today has helped you and you want to take it to the next level, then I'd love to play part in your preparation. So if you want to get in touch, then feel free to scan the QR code or go into bit.ly/SCA121, and we'll be able to work on a plan how to get you to pass your exam first time. So if you haven't joined our SCA support Facebook group, feel free to join the support group as well, because I do post various tips and insights on it regularly. So let me just recap on what we've covered today. Today, you've learned how to prepare for the SCA and how to pass. We've looked at the challenges and the pitfalls, and you've got an idea as in what to expect for the exam and what's the format of the exam. So let me just give you with some key takeaways. Make sure that you record and analyze your consultations. It's very important that you do that. Make sure that you're seeking constructive feedback regularly, because if you just keep practicing the same thing, you're unlikely to get the results you want. You want to practice, refine your consultation, and this is where you're going to get better. And reflect on your learning and make adjustment. So best wishes for everyone who's going to sit the exam. If you've got any questions, please feel free to ask me. I'm going to stay here for the next 5 minutes.
I have a question.
Yes.
I'm just wondering in terms of the group courses, um, like where we can find the details of that courses and what would be the fee for those courses?
So I'll share with you the link for the course. So if you're looking for the workshop one, then that will come down to £299. So I'll share the link in the chat box.
Thank you.
When are you looking to sit your exam?
March.
March, okay. So yeah, if you're sitting in March, there's still time. If you go on the website, then you'll find more details about it.
I think in the early stages of learning how to consult, people can be over-taught. There can be too much instruction going on. Remember when you were learning to drive, the first few driving lessons,